Good evening, everyone, and welcome to our webinar, Unveiling the Scope of Workforce Incentive Programs. My name is Erin Crimmins, a Workforce Development Officer at Western Vic PHN, and I'll be your facilitator for this evening. Alongside me is Katrina Pilbeam, also from the Workforce Development team here at WVPHN. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations. You can view the majority of our webinar recordings freely on our PHN YouTube Learn channel. We'll put the link to access our recorded webinar events into the chat. Please see our upcoming events on the screen now. You can register for our events on our website, and we will also put this link into the chat. A certificate of attendance will be emailed to participants, so please take a moment to check that your full name is displayed accurately on your screen. If not, or if you're unsure, please rename yourself or type your first and last name into the chat box now. This will ensure that we can issue you with a certificate of attendance. This event is being recorded, so please keep yourself on mute unless you would like to ask questions during the designated Q&A time at the end of the formal presentation. We encourage interactivity and discussions, and please feel free to type questions into the chat box at any time. Your feedback is important to us, so please take the time to complete the event survey after the webinar. There will be a link to this in the chat box to complete the survey. So our presenter for this evening is Wendy O'Meara from Larter Consulting. I'll just hand over to you now, Wendy.
Thank you so much, and welcome everyone. I'll just share my screen. So I am very privileged to be presenting to you tonight. Thank you for inviting me and thank you for joining. I would also like to pay my respects to the traditional custodians of the lands which we are virtually meeting tonight, and to pay my respects to their elders past and present. And I'd also like to extend that respect to any First Nations people who are with us tonight. So we've got a big topic tonight, unveiling the scope of practice incentive and workforce incentive programs. So I have added a little bit of an overview of the practice incentive program as well, just for anyone who may be interested, because there's a lot of it that a lot of practices don't actually understand. So I'm hoping that will be of benefit for you all tonight. So to get started, the learning objectives at the end of tonight's session, each participant should be able to recognise the components of the practice incentive payment, the workforce incentive payment, and the SIP, which of course is the GPAC incentive that we've been introduced. I will only cover off on that very briefly. You'll also be able to recall how you can maximise payment streams and meet ongoing reporting requirements, along with the integration. We're going to talk a little bit about the integration of allied health into our practices, because not only is it a great thing to have, but it also can improve our WIP payments. If we get time, I am going to touch very briefly on the chronic disease management changes coming in July, but that will only be if we get time. So let's start with the workforce incentive payment, or as we commonly call it, the WIP. To start off with, we're going to look at the three different streams that are available to us. We have the doctor's stream, where payments are made directly to your GPs and rural generalists who work in MM3 or 3 to 7, or MMM, I should say. Then we're going to look at the practice stream, which is where payments are made directly to the practices who employ nurses and allied health workers. And the final one, which has been around for about a year now, I find a lot of practices or GPs are still not aware of it, is the rural advanced skills. So I will cover off on that briefly, because we only have that for 3 years. So 23, 24 and 25 are the 3 years we can claim that. So I thought it would be timely to discuss that tonight. All right, let's start off with our doctor's stream. So the workforce incentive payment doctor's stream was introduced in 2020 as part of the Stronger Rural Health Strategy. It replaced the GPRIP, or the General Practice Rural Incentive Payment, with the aim to provide financial incentives to GPs or to doctors working in regional, rural or remote communities. It promotes careers in rural medicine and payments are made directly to the doctors who bill the required number of MBS services. To be eligible for the doctor stream, you must have a current provider number. You must provide eligible Medicare services in MMM 3 to 7. You must meet the required number of active quarters, and you must have your current bank account details registered with Services Australia, specifically for the WIP. So there is a section in your profile where you can add bank account details related to the incentive you're claiming. So you need to ensure that your payment is, that your bank account details are registered, and also if you change locations or change bank accounts, that you notify Services Australia as well. There are two types of payment streams in the doctor stream. We'll look at the central payment stream first, which is basically for any doctor who bills eligible MBS services such as professional attendances, so your level 23s, 36s, after hours numbers, nursing home numbers, including telehealth, along with any diagnostic procedures. You do not need to apply for it. If you are working in an MMM 3 to 7 and have billed the appropriate number of services or the minimum number of services, it will automatically be paid to you. The payments are calculated according to the number of active quarters, and I will explain what that means to you shortly. The quarters become active when you meet the minimum activity threshold, which is $6,000 of eligible primary care services billed under MBS. If you're a busy general practice, you could meet that in a week. So it's not hard to meet the 4 quarters eligibility. There is a maximum quarterly activity of $30,000. So even if you bill $300,000 for the quarter, the maximum that you can be paid on is the $30,000. Then we're going to look at the flexible payment stream. So this one is where you need to actually apply for this payment stream if some or all of the activity you are doing does not reflect an MBS billing. This happens with optometry, dentistry, and the bulk billing incentives. And there are also other services I'll discuss shortly, or other providers. So basically you're providing non-eligible MBS services, or you're undertaking a general practice training under an approved training pathway. So if you are under any of the training pathways, which I'll show you shortly, you are able to apply for the flexible payment stream. You must apply through the Rural Workforce Agency. In our case, it would be RWAVE for being Victoria, but if you're located in other states, you would apply to the appropriate agency within that state. And the thing that I found interesting is if you've received a payment under your central payment system, but didn't actually meet the top payment, you can also apply for a top-up payment under the flexible payment system if some of that quarter was also billing, for example, your bulk billing incentive. So that was really interesting for me. The approved training pathways we talk about are the AGPT, so the either ACRM or RACGP, the RACG Fellowship Support Program, independent pathways through ACRM, the PEP program or the Practice Experience Program through the RACGP, and of course the Rural Vocational Training Scheme or the RVTS, which is either ACRM or RACGP as well. So if any of your doctors are working within these training pathways, they may be certainly eligible to apply. Oh, and of course the Rural Generalist Training Scheme also under ACRM. So lots of opportunities for GPs to apply for these payments. What does it look like for a maximum annual payment? So for a VR doctor, the minimum payment is, they're based yearly. So if you look at, for example, I think most of your practices are in MMM5. So you would look at year 1, there are no eligibility for payments because you must have worked at least 4 quarters. So there's your first year. However, on the first quarter of the second year, you can start to make claims for payments. In year 2, the maximum is 12,000, right up to 23,000 in MMM5. If you are in MM7, then the total or the maximum payment that you may be able to claim is $60,000, which is quite a considerable chunk of money to incentivize GPs to work in MMM7s. If you are a non-VR doctor, so this has only been introduced 12 months ago. Previously, non-VR doctors weren't able to apply for the doctor stream. However, that has changed, and the payments are basically 80% of the VR doctors. So as you can see, or as you may recall, the MMM7 was 60,000 for a VR GP. It would be 48,000 if you were non-VR. So it's basically 80% of the total. What is an active quarter? So basically, when we're looking at payments, they're determined by activity within a payment quarter. Active quarter is when a medical practitioner meets the minimum activity threshold, which, as you remember, was $6,000 under either the central payment scheme or the components of the other scheme. New participants are eligible for initial payments. So if you are just registering for this doctor stream now and you are a new participant, you are eligible for the program if you are predominantly practicing in MMM 3 to 5. You'll be eligible for the initial payment at year level 2. So as I said before, the first year you don't receive any payments. Once you transition into the second year, you'll then be eligible for payments. If you are in MMM 6 to 7, you'll be eligible after the first year. So they, again, another encouragement to work more rurally or remotely is by working in MMM 6 and 7, you're able to be or apply for the payment 12 months earlier. Participants will advance to higher year levels after each payment. So each year that you transition through, each year you stay in that rural area, your payments become higher until you reach the maximum level of 5, where the payments will then continue to be made at that level each year. Unless, of course, you go on extended leave. If you are on extended leave, you won't be meeting the quarterly requirements, so therefore the payments will be ceased. You will not be removed from the program. You'll just become inactive until your payments start up again or till your services start up again. Payment quarters are prescribed time periods, which allows us to calculate. So quarter 1 is starting first of the financial year, July, August, September. And then we have quarter 2, 3, and 4 concurrently up till the end of June the following year. So this is where they're looking at the number of services and what quarters the time actually reflects. So if you start a new practice in August, you may not necessarily qualify for the first quarter because you're already a month and a half through that first quarter. So just they're the quarters that you're able to. When we're looking at a session under the other programs, to be eligible, you have to do, refers to an accumulated period. So a session is basically 3 hours. So when a GP is looking at how many hours do I count for a session, because the focus payment stream is on sessions, not on number of services, because this, remember, this is for people who may not be providing MBS services. With an active quarter, just a bit of a summation there. If you have billings of 30,000 or more in one active quarter, you will receive the maximum payment. If you have between 6,000 and 30,000, you'll get a pro rata payment depending on the number of services you have provided. And if you are billing less than 6,000 in a quarter, you're basically classed as inactive and you'll be ineligible for payments through that quarter. With the other payment sessions or the focus payment sessions, you have active sessions. So in each quarter, you need to have basically, if you are inactive, you're doing less than 21 sessions in a quarter. If you are active, you are doing between 21 and 104 sessions. And of course, when you're active and receiving the maximum payment, the minimum is 104 sessions to be eligible for that. So eligible payments under the FPS, basically in each area, the services are provided. So if you look at MMM 6 to 7, it could be that you are a Commonwealth or state salaried medical practitioner, so you're providing primary care services but not charging Medicare. If you're MM 3 to 7, which is where most of your practices lie, it could be someone working at an Aboriginal medical service where Medicare services are not attracted, or, for example, the flying doctor's service, who are also ineligible for primary, who are billing or providing eligible primary care services. As I said before, participants on approved training pathways are also eligible to apply for the FPS payment stream. All right, Now we're going to look quickly at the rural advanced skills. So this is one I mentioned has only been around since January last year. In this one, there are also 2 streams. It gets really confusing, doesn't it? All these streams and payment methods. And so we have the first stream, which is emergency medicine. Basically, there is a payment available to general practitioners up to $10,500 per annum for providing either a minimum level of emergency care. So they could be working in a hospital doing sessions. They might be co-located with a hospital and spend a lot of their time seeing patients who present to the emergency department, or providing emergency after hours care. And then you have your advanced skill payment, which is another payment of $10,500 per year for doctors who hold advanced skills. So it could be obstetrics, anesthetics, surgery, mental health, or First Nations health. Now, all of these, I apologise, I've spelled anesthetics wrong. All of these specialty or these advanced skills must be certified, so they must do appropriate training and provide the certificate of training to the Department of Human Services. So when I say mental health, I don't mean just mental health where you can do a mental health plan. I mean things more like the FPS strategy training or other highly advanced skills. And there is an extensive list on the Rural Advanced Skills website of all the different certificates that are available to general practitioners. So if you're looking at improving your skills or advancing the services you can provide to patients, it is a great opportunity to undertake those training opportunities, and that will allow you also then to claim a further $10,500 per year. There are minimum service levels as with all WIP things, and there are three levels. So basically, level A means you basically participate in 11 rosters. What does that mean? It basically means that you'll be rostered on to either an urgent care centre or to an after-hours service located within your hospital where you are able to, and you're rostered on for 11 sessions in that quarter. And it goes right up to 48 rosters. So someone who is actively working in any of those environments will be eligible for the level C payment, which is up to 48 rosters in a quarter. This probably explains it much better than I could. When you look at it here, the first thing is whether your GPs are full-time or part-time. So to be full-time, the requirement is only 0.6 of an FTE. And to be part-time, it's basically below 6 of an FTE. With a minimum of 96 primary care rosters if you are a 0.6 and 48 if you are 0.6. Part-time, below 0.6. Down the bottom there, stream 1, it basically shows how the payments are made. So if you are participating in level C, which as we said before was 48 rosters, and you're working in MMM 6 or 7, you'll receive $10,500. And then it staggers down depending on the number of hours you work or the number of sessions you work and the location where you're demographically located. With the advanced skills payment, it's the same thing. 3 levels of payments. Again, how many rosters you participate in will determine the amount of money that you'll pay. I should say we'll be providing a PDF of this presentation, so you'll be able to use that as a resource. Hence why some of the slides look a little bit wordy, but I want to make sure that you understand what I'm saying when you're rereading it. So that's the advanced skills. Really short overview. May be applicable to some of you GPs, and if not, maybe something to consider if you wanted to look at improving the services that you can provide for your patients, particularly if you're working in the more rural or remote areas, or more rural, I guess. Now we're going to look at the practice stream. So this is a payments made directly to the practice. There are 3 payment streams available under the WIP practice stream. You have your quarterly incentive payments, you have your quarterly rural loading payments, and you have an annual DVA loading payment. A lot of practices are not aware of this. This payment is displayed on your November statement. So your quarter ends in October, you receive your November statement. It will list all of the DVA patients that you have provided care for over the previous 12 months. It will also then tell you the proportion of care that you have provided, which is really timely or handy if you would like to register patients in the Veteran Affairs Coordinated Care Program, which is a huge incentive financially for practices. So if you have a patient who is on your list and you have provided 100% of their care, you are absolutely going to be able to register those patients for that CVC program. Payments are calculated and paid retrospectively. So they're looking at the quarter before whenever they are calculating payments. Obviously, they need to wait for the data to all come through before they can calculate payments. So it's always a quarter behind. They would look at, when they're calculating payments, they look at several things. They'll look at your application and any subsequent amendments you've made, any details from your quarterly confirmation statement, which we all know is due each time we lodge our WIP payments. We confirm our hours and our practitioners, and the Medicare and DVA data that we have used or that we have produced over that final quarter. So all of those things are used to calculate what type of payments we as a practice are going to receive. The Workforce Incentive Payment practice stream encourages multidisciplinary, team-based model of care. So the more allied health nurses and other services you provide, the more available you are to claim the WIP, or the higher amount you're going to receive. I do want to clarify one thing. When you have allied health who are working from your practice, so they rent a room or they subcontract to you and you are not paying them, you cannot claim their hours. Okay, a lot of practices get confused. We've got a podiatrist and a physio that comes in twice a week. Can I claim their hours? Are you paying them? No, then no, you can't. So if you are employing them, then absolutely you can claim their hours. And that's what we're going to touch on in a little bit later, on how we can, what the benefits are to us for having allied health services available at our practice. So the financial incentives are available for us to engage. Now, they do not cover the full costs of practice nurses, for example, but they certainly provide a good chunk towards the cost of uniforms and advertising and recruiting and training, and just they do subsidise their salaries. They're available for practice nurses, both registered nurses and endorsed nurses, midwives, any allied health professional, and any Aboriginal or Torres Strait Islander, either health worker or health practitioner. The payments, as I said, are designed to assist the practice with the cost of engaging these eligible health professionals. It may be you look at engaging a podiatrist and you may then need to get a podiatry chair. So maybe you would look at getting a physio, then you need to get equipment for that physio to use. So it's designed to allow us to be remunerated, I guess, for a little bit of the cost that's involved in acquiring these services. So the payments are specific. There are specific requirements before you can receive the workforce, the WIP practice stream. You must be accredited or registered for, with the aim of being accredited within the next 12 months. If you are not accredited after 12 months, your payments will be withdrawn. You must employ at least one full-time GP. Now, that doesn't need to be just one GP who works 38 hours. It can be a combination of two part-time doctors. So you have one FTE calculated with two part-time doctors' hours. You must engage at least one health professional, so a nurse or an Aboriginal health worker or someone on the list that I previously gave you, or an allied health worker. You must be eligible to receive the practice incentive payment to be able to receive the workforce incentive payment, and you must hold public liability insurance of at least $10 million. So very similar criteria to when we register for the PIP. The same requirements are applicable when you register for the WIP. What are eligible health professionals? These are just a few of many, many, many more. When we look at the main ones in general practice, we're looking at our nurse practitioners, our registered enrolled nurses, midwives, and our First Nations workers, but we're also looking at the allied health components, so audiology, chiropractor, physio, diabetes educator, dietitian. There are so many, and they all bring something to the service we provide. So if you're looking to attract allied health, keep this in mind when it comes to the cost of setting them up or establishing them. The incentive payments are basically based on calculation. So from the 1st of July 2023, the maximum incentive was increased to $130,000 per year. It was previously $125,000, so it has gone up to $5,000. The biggest question I get around this is what is a swappie and what is a whippy? So I'm going to explain that off to you. So a swappie, or the number of standardized whole patient equivalents, is and I'll show you how that's calculated. The number of hours that your nurse or your allied health practitioners worked, where you are demographically or geographically, and what loading which will then apply to what loadings you're going to get. And as of August 2024, the WIP practice stream payment will index every year. So the first time that's happened, last year, it was indexed for the first time, and we hope to see index appropriately each year moving forward. So basically, to receive the maximum payment for the workforce incentive practice stream, you must have a swappie or a standard whole patient equivalent of 4,000 and more. You must have a combined working hours. So this is the working hours of your nurses, allied health, any other practitioner, of 50 hours and 40 minutes per week. So if you have one full-time nurse and one part-time nurse, you'll have already met the minimum requirements. That's what it looks like when you tritate it down. So as I just showed you, 4,000 swappie, the bottom one, 50 hours and 40 minutes gives you the total $130,000 if you are employing registered nurses, midwives, or AHPs, or allied health professionals, or 65,000 if you are employing enrolled nurses or Aboriginal Torres Strait Islander health workers or health practitioners. So it's basically double by employing either a nurse practitioner or a registered nurse. So if you're looking at attracting more staff or employing another nurse, and you're looking for the maximum incentive, then you would be best to employ a registered nurse. When a practice participates, we have requirements. So we have reporting requirements. We must advise of all our health professionals' APRA numbers, so their registration numbers. So we need to make sure that we are constantly checking that they are registered and that they're eligible. We must report the average weekly hours, and that's the key word, average, and I'll explain that in a moment. We report them quarterly, and we can either lodge them through Quota or on the paper form that we normally receive 2 to 3 weeks prior to the end of the quarter that we're currently in. Oh, we've got a dot there in the middle. When you're reporting the hours for your eligible health practitioners or your health professionals, you must report the average weekly hours, not the total hours worked. So I'm going to explain that in an example in a minute. So if you have a nurse who works straight 38 hours every week and there is no change and you only have one nurse, you're going to report 38 hours a week. However, if you have multiple nurses who chop and change their hours, you need to calculate. So say you have a part-time nurse who works 10 hours this week and 20 next week and 30 the week after and 5 the week after, and constantly is upping and down, changing her hours, you would have to calculate the total hours and divide it by the number of weeks in the quarter to get her average, his or her, I should say, average working allowance. If your eligible health professionals, so your nurses or any AHPs are on paid leave, during that quarter, these hours can be included, as can the hours of the person you've got covering. So if I have a nurse who takes 2 weeks annual leave during the quarter, those 2 weeks annual leave will be added to the calculation I lodge when I lodge my hours for the quarter. Unpaid leave or leave paid once the health professional ceases, so termination payments, cannot be claimed. So if you're paying out a nurse who's been with you 20 years and she's got, 30 weeks of annual leave, you cannot claim those payments, nor can you claim someone who decides to take unpaid leave. So I put an example here, which I think makes sense. I hope I'm going to be able to sell it to you. So you have 2 nurses. A nurse is engaged for 15 hours for 4 weeks. and 20 hours for 9 weeks. 4 and 9 make up our 13 weeks of the quarter. So how am I going to calculate her hours? Simply, I'm going to calculate the 15 hours a week by the number of weeks she worked, which is 4, so that gives me 60 hours. And then I'm going to calculate the number of hours she worked for the 9 weeks, which is 9 by 20, which is 180. I'm going to then divide that number by 13 weeks, and that is going to be that nurse's average working hours, which is what I will report when I lodge my WIP payments or my WIP calculations. The other thing to be important is, because we need to be really accurate with these, the minutes must be converted from the percentage of the hour to actual minutes. So as you can see, I have 18.46, which is a percentage of a whole hour. Basically, to do this, you just take the decimal place and multiply by 60 minutes. So in that case, 0.46 multiplied by 60 minutes equals 28 minutes. Therefore, my reporting would be 18 hours and 28 minutes for that quarter. This is really important, because if you over report your hours on a regular basis and you get audited, you may need to pay some of that money back. So I have a fantastic spreadsheet that I use. So just a little tip, because I like to share my tips. Instead of me stressing out at the end of every quarter on how I'm going to get, because as I said, I have 15 nurses. So instead of thinking, oh my gosh, how am I going to get all these hours and divide it all by 3, I created a spreadsheet that basically I enter in the quarterly, the fortnightly that my staff are paid. So on one side are all the dates. Across the top are the nurses' names. And each pay period, I have the pay slips in front of me. I take from the pay slip, because that's exactly what I paid her, and put it into that quarter. It calculates itself. So when you've entered all the information, it will calculate the exact income. All you'll then need to do is calculate the minutes or the percentage of minutes back to give you the final number. I can't quite work out how to do that in the spreadsheet. So if anyone would like it, I'm going to send it through to Katrina anyway. And if anyone would like a copy, please yell out, because it's such a time saver when it comes to calculating. And you now have evidence to provide if you were ever audited about where you got your calculations from. So I touched before on the benefits of engaging allied health in general practice. I think it's a really important thing for us to consider, and a lot of funding is going towards general practice engaging allied health. And I think our biggest problem is not that we don't want to engage them, it's finding the providers to engage. So it's very hard to get allied health workers attract to your practice, isn't it? That's one of our biggest problems. So employing allied health professionals, or AHPs as I'm going to refer to them, within general practice does offer significant benefits. It enhances your patient's care. It boosts job satisfaction and promoting better outcomes for individuals and the practice as a whole. So you have that one-stop shop where you can provide services to your patient through all of the criteria that they require. And AHPs such as physios, OTs, and speech therapists provide specialised services to address not just their physical, but the mental and functional health issues. So it's another scope which complements the roles of our GPs, resulting in a more comprehensive patient care. And the benefit of having those providers working in your practice is you're able to talk to them about those patients. You're able to participate in case conferencing with them and be able to claim revenue from that. This is some information from the Navigators report from the REC GP Health of the Nation in 2024. And it looked at what the composition of allied health workers allied health workers was in general practice at that time. As you can see, 92% of practices employ a nurse, 52% employ allied health professionals, and then we drop down to 21 for OMPs, 12 for pharmacists, and 5% for Aboriginal health workers. So there's a big disparity between our practice nurses and our allied health. Practice nurses have been around a lot longer, or we've been using them a lot longer, whereas allied health is now becoming so much part of our work that practice are starting to now look at how can we engage these people. when they asked the GPs their perspective of what services would most benefit the practice, again, 88% said practice nurses and 75% said mental health professionals, so psychologists. You can get OTs who are also trained in mental health services if you're struggling to get a psychologist. And then it went down to 67% of doctors who would like allied health. I would love to see that figure up at the same figure as practice nurses. And as you can see, it scales down according to the importance that GPs felt. What was surprising, that was only 12% of pharmacists already working in general practice, yet GPs would like to see an increase of 33% of GPs said they would like to see pharmacists working within their practice. So that I found interesting as well. The other benefits, of course, to our allied health employing is the reduced pressure on our GPs. They can handle specific aspects of the care, including chronic disease management, rehabilitation and mental health support, which allows the GP to focus on core medical care and not have to be seeing, not that they don't want to see them, but you know, if you're a practice that's limited with GPs, perhaps look at an allied health professional to support your GP in the care of these conditions. It also allows access to care, or better access to care, because they can provide services in the community. So our podiatrist goes out to the community for those residents or those patients who can't come in, or at your practice. If you don't have the space at your practice, perhaps getting an allied health worker that can go out to the community. It makes it easier for patients to access care and improves adherence to the program. So when we do our chronic disease management and we put all these things in place, then if the practice or the patient can't get an appointment with a physio or a dietitian or any of those services, then they're less likely to adhere to the treatment plans we've put in place. Integrating allied health professionals into practice also improves data quality. So if they're using your clinical software and recording notes, then you're going to have appropriate data. You're not going to be waiting on letters to come back, or you know, any information that's required will be available to you immediately. Collaborating with multidisciplinary team boosts job satisfaction, but it also leads to a more motivated and productive workforce, because we can, you know, move our patients around the services. So if a GP is overloaded with patients, we can, you know, perhaps move services to an allied health worker who'll be able to assist that GP in managing that patient's care. And integrating AHPs can provide career development. So as a GP, my GP is always looking to improve their skills. So they are working side by side with a podiatrist or a physio. They're going to learn from them. You know, a wedge resection is one of those tricky procedures that GPs do, and a lot of GPs are reluctant to do them. Whereas if they had a podiatrist to show them the appropriate way, they may be more likely to do that than if they were just left to their own devices. And let's not forget, with the expansion of telehealth, allied health professionals now have the ability to provide services via telehealth to remote patients or patients who, for whatever reason, cannot access care at your surgery. And there has been an expansion to include allied health in case conferencing. So allied health can now participate and be funded for case conferencing. That's been around for a few years, but again, a lot of practices or GPs are not aware of that. So if you've got allied health people, professionals working within your practice, you can set up really quickly a case conference around a patient who may be in attendance. The data from across the sector indicates that half of general practice are planning to, so we're going back to that Health of the Nation survey. The data indicates that at least 50% of general practice are planning to increase the number of healthcare professionals within their practice, with almost 3 in 5 practices planning to expand the services offered by GPs and other healthcare professionals. So we're looking at, and this was, you know, coming up 12 months ago. So we're looking, I'd love to see what the figures are now, but we're looking at, everyone is aware of the benefits, not only for your workforce incentive payment, but also for your for your practice longevity and for that, multidisciplinary team care approach that we so like to provide for our patients. Okay, so we're going to cover off on the PIP just briefly, or, I'll cover off on it, and then if we've got time, we'll talk about the chronic disease. So please remember, if you have any questions about something that I have mentioned, please pop it in the chat so that we can come back to it at the end of the session. So the Practice Incentive Program is basically designed to encourage us as general practitioners to continue to provide good, high quality care that enhances and improves health access and outcomes to our patient. That is the terminology. When you say, what is the PIP? That is what the answer is. It's made up of 3 payment streams and 7 individual incentives. You may be registered for 1, for 2, for none, for all. To be eligible for the PIP, you must be operational. What that means is you must have a physical location and be seeing patients. You can't be a mobile GP service that goes around to aged care facilities, although I do believe in the future they are looking at expanding the eligibility or relaxing the guidelines to perhaps include these providers. You must be accredited or registered for accreditation. You must hold your $10 million of public liability insurance, and GPs and nurse practitioners must also hold their own individual public liability insurance. How are our payments calculated? You get that number on your sheet every 3 months and you look at it and think, I wonder how they got to that figure. So hopefully I'll be able to explain to you how they calculate. So the first thing they look at is the measure of your practice size. Now, it's not about how big your building is. I'm in a huge general practice. We have 27 consulting rooms. We have lots of different rooms. We have a 6-bay treatment room. We're huge, but that doesn't matter to the PIP. They're looking at the number of services we provide and the range of things we can offer our patient, the number of practitioners we have. So that is what they mean by practice size. So don't think if you're in a small 3-room practice that you're not going to be eligible, because it's not what that means. The whole patient equivalent and the standardized whole patient equivalent, I'm going to break that down for you so that you actually understand the next time you look at your statement what it actually means. So what is the whole patient equivalent? Doesn't it mean that every patient I have is a one whole patient? I've got 5,000 patients on my book and they're all one patient. That's not how it works. So the way the payment is calculated is on the dollar value of MBS services provided in a 12-month period. So let me give you an example. Wendy O'Meara has 2 doctors because I can't always get into Dr. B, so I often will go to Dr. A or Clinic A for a script or something simple. So during my 12 months, Wendy O'Meara has Medicare services worth $400 for Clinic A and $600 for Clinic B because I spread my services over those 2. So what does that mean? Wendy O'Meara is 0.4 of a whole patient equivalent for Clinic A and 0.6 for Clinic B. So even though I'm one person, I'm only getting, Clinic A is only providing 0.4 of my care and Clinic B is providing 0.6. However, if we change that and Wendy O'Meara's, all of her services were with Clinic A, that would make me one whole equivalent. Okay? So basically what that means is the more services we provide to our patients and the less services others provide, the higher our whole patient equivalent is. So that's the first step. So when you get your PIP statement, you'll see 2 numbers, your WPE, and then you'll see your SWPE. And that's what we're going to look at now. How do they calculate from one whole patient to the payments that we get? It's called waiting, not waiting in a waiting room. It's called waiting as in burden down. So when you look at, the first thing I do is get the numbers and then they weight it on several things. The age of the patients that we're seeing, the gender of the patients that we're seeing, they are significant in the weighting, and I'll show you how that's done in a minute on a simple graph. So weighting recognises the different care that patients require at different ages or different stages in their life, along with their gender. So female over 75 are the highest weighted because they're more likely to go to the doctor and they're more likely to address any health concerns. It differs between male and female because male, as we all know, don't like going to the doctor, so they're less likely to go as many times as their female counterparts. The total, and that is how your total standardized whole patient equivalent is calculated, and that is what your incentives are calculated on. So to put it in simple form, this is what the weighting looks like. This changes from quarter to quarter. So this is the weighting from the last quarter. So as you can see, if you have a child who's less than 1, they're only going to get weighted or calculated out at 0.56 if they're female. However, if we go to the other end of the scale and we have a 75 plus female, she will be calculated by a percentage of 2.125. So a 0.5 will be calculated or multiplied by 2.125, which may then give us 1.6. Why don't you look, when you see it makes sense. Young children under 4 do require a lot more work, immunizations, and they're always getting sick. Then you have that age group, the 45 to 64, which is the lowest weighted from one of the lowest. 25 to 64, I should say, are the 2 lowest weighted. What does that mean? If you are a practice that only services young, healthy, or younger females or younger males, you might be a sexual health clinic, or you might be a clinic that's got a very young population, and your clinic attracts all the young ones and the clinic down the road seems to attract all the elderly patients, your standard whole patient equivalent is going to be less than your whole patient equivalent. However, if you're on the other side and you had all those elderly ladies, your standard whole patient equivalent will be higher than your whole patient. This is what my practice looks like. So I have a whole patient equivalent of 7,353, and I have a standardized of 7,400. So what does that mean? It means we provide pretty much services across the board with a higher tendency for females, because otherwise we'd be low. So as you can see, we pretty much cover if I was to look at that, I would say, we pretty much cover the full ages with the same amount of services. So I hope that makes sense. I do try to make it as simple as possible. I hope I haven't lost half of you and you're thinking, oh my gosh, I don't even know what she's talking about. So as with everything, we have obligations. The obligations your practice must do or must meet are be able to prove the claims for payment. Hence, if you take on my spreadsheet and use that, you'll be able to prove your claims for payment. You must provide accurate information to the department. And if you've never noticed, when you go to click submit on your workforce in payment hours, you're basically clicking a declaration to say, I declare this information to be true and correct. So you clicked it, you submitted it, you're covered by your practice, but if I'm going to do that, I'm going to make sure it's right. You must keep a copy of all documents related to the PIP, including any registrations or insurances for a minimum of 6 years. So you need to keep your insurance that renews every year for the last, you need to keep 6 years copies of evidence that you had current insurance. You must confirm all details in the annual confirmation statement, which we know is coming up. It's coming up in May, so please don't forget to do that. You should receive it mid-April, and you have until I think it's the 31st of May to actually complete it. If you don't, you may have payments withheld, or your payments may not be correct. And you must tell Services Australia about any changes to your practice arrangements within 7 days of the change, or at least 7 days before the point if you are aware of it. What does that mean? It means a practitioner leaves or joins the practice. There's a change to the authorised contact person or a change to your bank account. Changes in your accreditation agency or your status. You may have failed accreditation, which would be unusual, or you may have applied for accreditation and not got it in the 12 months that you had to do it. Or as I said, you may have changed from AgPal to QPA or to one of the other providers. You may move practice. You may build a new purpose-built building right next door and you move your location. You think, I'm only moving next door. I don't need to tell them. You do. If you're changing your location, you must tell Services Australia. You must also tell them if it's a change of ownership or an amalgamation of your business. And you must notify them if there's any lapses in your public indemnity insurance for your practice or each provider. So if a GP forgets to pay their public indemnity insurance, but they still pay it, there will be a period of time where they are not covered. So that's why I'm very particular about ensuring that I have copies of my GP's registration, insurance, all those things the second I know they're due, and they all know just to provide them to me. And any changes that affect your eligibility for each incentive. So if you are claiming for a particular level of after hours care and you either increase that after hours care or you decrease it, you must tell them because your payments will be then inappropriate, particularly if you are decreasing. You'll be being overpaid and may have to pay money back. So as I said, 3 streams. We have the quality stream, the capacity stream, and the rural support stream. And I'm just going to touch briefly on each of those. So the quality stream is basically for participation in your continuous QI activities. And this is where your PHN is the go-to people. They can help you to undertake quality improvement. They can give you resources you require. They provide you with information that you share with them as far as data goes. So you get reports on your practice and where you are in your, within your area, where you are sit amongst your peers, and you look at those reports and say, gee, I've only got 50% of my smoking status recorded. I'm going to make that a quality improvement and I'm going to get that up to 75% in 12 months. So that's what they're talking about. And the PHN are your most valuable resource when it comes to performing these activities. There are specific areas you should focus on. And the data that and the quality improvement activity that you undertake should be informed by your data and the needs of your practice population. There is an eligible data set that you can use to guide your quality improvement activities, and the data collected is against specified improvement measures. Participation in de-identified data. So this is where you do the sharing of data between the PHN on a quarterly basis. The PHN will then provide a de-identified report, feedback via reports to your practices to assist you in targeting those priority areas. So they'll say to you, this is the areas we think you could improve on, or would you like to undertake some quality improvements on these areas? And there are 10 improvement measures. I'm not going to go through each of them. As I said, you'll get a copy of this, but these are basically the 10 that we are guided to use when we're looking at our improvement measures. Excuse me. Eligible practice can receive a maximum payment of $12,500 per quarter for participating in the quality improvement incentive, or $1.25 per swappie. So once you know your swappies, you can calculate what your payments are going to be. Keeping in mind your swappies will change from quarter to quarter, up to a maximum of $50,000 per practice per year for being involved in the quality improvement incentive. In order to receive this, you must be sharing data. That's the only real requirement at this stage, that you must share data with the PHN, and these payments are also subject to rural loading. The Indigenous Health Incentive has had some major changes, so I just want to touch on that briefly. It was introduced 15 years ago. It's had a lot of rework done on it. The incentive that we first got in 2010 is now very different to what we have in 2025, but it was designed to support practices to improve the care that we provide to our First Nations patients. The only criteria for a patient to be eligible to re-enroll is they must self-identify. They do not need to provide evidence of their ancestry. They just have to say, I identify as either Aboriginal or Torres Strait Islander. The other criteria is that 2 staff members, one being a GP, must complete cultural awareness training within 12 months of registering. If you registered in 2010, like we did, every 5 years, some staff members should do the cultural awareness training, because if you don't use it, you lose it, and it's good practice to do it, because it's not just about First Nations patients, is it? It's about all the other cultures that we may come across in our working lives. And has been expanded now. So the eligibility previously was for chronic disease only. It has now been expanded to include mental health as a disorder, that you are able to register your First Nations patients under the Indigenous Health Incentive. Final criteria is they must have had or been offered and refused a First Nations health assessment or a mental health plan. Okay. Now, the changes that I was referring to before, eligibility has also been expanded to include children under the age of 15. Previously, it was only 15 and older that you could register. You can now register anyone of any age. GP mental health plan added as an eligible item for purpose of outcome payments. So we're going to look at the outcome payments in a moment. And the mental health plan was another item that has been added to that. The requirement to deliver a certain number of services in a calendar year has been replaced with a 12-month rolling window. So if you enrolled a patient in July, you only had then 12 months from that time to complete those services. I beg your pardon, you only had till December to complete the services to be eligible, whereas now it's a 12-month rolling window from the time you register them to the time you have had to provide those services. And the changes as of this year is you no longer have to re-register your patients on PROTA every year, and a lot of practices didn't even know they had to do that. You now only have to register them once on the 1st of January. If you go and register all of your patients, you will never have to register them again. Obviously, if you register a child, when they reach the age of 15, they then will be given a choice whether they want to stay on or whether they want to be removed from the program, because they become classed as an adult and able to determine whether they'd like to stay on or not. And we have lost the $150 sign-on payment that was initially given to us when we enrolled a patient. So what do the changes look like? If we look at the Larter third column, the 1 January 2025, we are still eligible. So if you have not registered for the Indigenous Health Incentive, you can register or sign on, and you'll receive a once-off payment of $1,000 for your practice, not for the number of patients you register, a once-off $1,000 payment. The patient registration payment, which was $150, then it went to $100, now it's $0. So there is no payments for registering your patients. However, the outcome payments have increased. So as you can see, tier 1 payments have stayed the same across the board at $100. If you either prepare and review your GPMP or chronic disease plan, or prepare and review a mental health plan, or complete 2 reviews of those, you have met the requirements for tier 1. Then in the final 12 months, or the remaining 10 months, say you did those in the first month, the remaining 11 months, you only need to provide a minimum number of 5 eligible MBS services. So it can be just standard consultations. It could be another health assessment, because as we know, with the First Nations, we can do those every 9 months. You'll then be eligible for a second tier payment, which is $300. So the payment is still, it's exactly the same as it was in 2023, $400 a year. It's just moved from the front of service to the back of service, which makes sense because there's an incentive to actually provide the services where previously there was none. So something you should be aware of if you have participated in it, or you've been, thinking about doing it, or you're just not doing it really well, this is a time to get cracking on that. Then we can move to the capacity stream, which is basically in ensuring or enabling us to keep up to date with digital health. Now, I know your PHN is all over that, because I did some work with them last year on digital health and improving the tools that you've got available, which I think is above and beyond, because I've never known a PHN who's gone to so much detail to provide their practice with such useful tools. With this incentive, there are 5 criteria. You must integrate health identifiers into electronic records. That's both your practitioner, your patient, and your nurses. You must be secure messaging capable, so you can receive and send messages in a secure platform. You must record, your data records must be adequate, and you must be coding correctly. You must be using electronic transfer of prescriptions, and you must be uploading to My Health Record. And as we know, the only thing that brings us undone in this one is the My Health Record, because if you don't meet your minimum shared health summary uploads in the quarter, you will not receive your payment. So please be aware of what your minimum is so that you can ensure you meet it early and then you can forget about it. Integrating health identifiers is basically ensuring that, as I said, all of your GPs, nurses, and patients' health identifiers are recorded in your clinical software. You can't send an e-script or access My Health Record without it. Secure messaging capability, basically have the ability to send and transmit. The important thing I want you to be aware of is second one, you must have a written policy around this. A practice policy about secure messaging is vital and is part of accreditation and part of ensuring you maintain eligibility for this incentive. And you must have digital security through a NASH certificate, which we all do if we're sending information to Medicare. Data records, ensuring that the diagnosis in your computer is medical vocabulary. Most of them have most clinical software already have the vocabulary built in. I think best practice is SNOMED. Practices must provide GPs again with a policy. So we have one policy that covers all of the e-health information. And if anyone would like a copy, I'm again more than happy to share that. And that your policy meets the RAC GP standards. And the electronic transfer prescriptions, we used to have a couple of options. We only have ERX now. They are the sole provider, the sole prescription exchange service, and scripts basically have to be sent electronically to the patient by that exchange service, which adds that added level of security. My Health Record, using compliance software, which we all do, for accessing and uploading health records. Something I do want you to know, if you access someone's shared health summary without their consent, you'll get a nasty letter from My Health Record. So we didn't realise, and we had a patient that was on the phone. We hadn't asked her, could we look up her My Health Record, and we were looking for a discharge summary that we knew would be in her My Health Record. So we popped on there, the doctor jumped on, had a look at it. Yep, it's there. He downloaded it. And a month later, we got a letter saying, why did you access patients? She never complained, but obviously something in that system said that we didn't have consent to do that. So we got a bit of a rap over the knuckles for that. So please be careful. If you're looking at I often get asked, how did they get my number? How do I know where did they get 35 shared health summaries for a quarter? Basically, once you know what your SWAPI is, your shared health summary is 0.5 of your standard. So if you've got 7,000 SWAPI, your shared health summary is going to be 0.5 of that. And both your GP and nurse can upload. Teaching payment, if anyone has medical students, they're aware what this is. It's basically only available to students enrolled in universities and completing undergraduate courses. There is a partnership with the university. There's session minimums, so 3 hours per session when you're teaching. You can claim 2 sessions per day per student with a maximum payment of $200 each session per student per day. So if you have 3 students and they're there 3 days of the week, you're basically going to be able to claim 3 students by 2, so 600 in the morning, 600 in the afternoon, so that's 1,200 by 3. You're going to be able to claim 3,600 a week for teaching. And the rule loading also applies on this. After hours, I'm going to skim off quite quickly. It's really quite simple. It's been around a while. There is a practice payment to incentivise the level of care you provide your patients after hours, whether you provide none, whether you provide some, or whether you provide all of it. Each of the levels is determined by how much care you provide. To be eligible, again, registered for PIP, provide after-hours care for patients in line with the RACGP standards. Maintain eligibility for the entire preceding quarter. What does that mean? It means if you do full after hours care for the first 6 weeks of the quarter and then drop back down to no after hours, you have not maintained eligibility. You therefore should not be claiming it. You must clearly communicate your after hours arrangements to your patients, whether it be on your website or on your practice brochure, on your phone recorded message. And that is how the after hours period is broken down. We have the complete after hours period made up of 3 separate areas. Outside 8 o'clock, before 8 a.m. and after 6 p.m. on a weekday, before 8 a.m. and after 12 noon on a Saturday, and all day Sunday and public holidays. That is our after hours hours, basically. Complete after hours is then broken down into 2 different categories. Sociable, which is between 6 p.m. Now, the reason they class 6 p.m. here, a lot of people are thinking, I thought after hours care was 8 p.m. Nursing home patients are 6 p.m. So if you're seeing patients in an aged care facility after 6 o'clock, you can claim the after hours item number. Broken down into sociable, which is between 6 and 11, when most people are still awake, and then from 11 p.m. to 8 a.m. when most people are sleeping. So that is what they call unsociable hours. Payments are based on your standard whole patient equivalent and are capped at 20,000 swappies. So if you have a practice that is huge and have 25,000 swappie, you will only ever be paid on 20,000. And what's important to remember is if the after hours care your practice provide changes, you must notify PIP, because if you don't, you may be required to pay money back. What does it look like? Look at the difference between level 1 and level 5. If you've got 1,000 swappies, you're going to get $1,000 for your after hours care. If you've got 1,000 swappies and you provide level 5 after care, you're going to get $11,000. So there's a big difference in the levels, and each level is broken down into whether it's just certain care that you provide with another company. For example, we claim level 5 because we provide full after hours care. So when the clinic is closed, Wendy O'Meara has the phone, she answers it, she will then contact the doctor to get them to call the patient if they're required. And finally, the rural support stream. We're a main practice located, it's basically for practices located outside of cities and major metropolitan areas. You are automatically paid a rural loading. It recognises the difficulty of providing care in rural and remote areas, and basically they are the loading. So if you are in MMM 1 to 2, there is no loading. If you are in 3, it's 15, 4 is 20, 5 is 40. Oh, and 6 should be 50, not 25. Sorry about that. 6 and 7 should be 50%. So as you can see, if you're claiming level 5 after hours care for 7,000 swappies, you're going to get 77,000 plus, if you're an MM5, another 40% on top of that in your payment. So it is definitely, oh, there we go. Level 7 is 50%. Level 6 should be 40%. So I apologize for my typo. The procedural GP payment may be relevant to some of you GPs if you're working in areas where there's no access, but basically it's available to anyone who performs minor surgical procedures. So delivers babies, assists with anaesthetics, or may assist in surgical procedures. And that includes abdominal surgery, gastroscopies, all those things. 4 tiers of payments ranging from a minimum of 1,000 up to 8,500 for a 6-month period. Again, it will be calculated on the number of services provided. It ensures access to services in the more remote settings. So again, encouraging GPs to advance their skills in order to provide a better range of care for our patients. And these are the eligible services. So obstetrics, GAs, regional blocks, abdo surgery, so and then gynecological, I can't even say that, and then endoscopies, so gastroscopies or colonoscopies. And the final one is the SIP, which we know as Dupaki. So basically, one slide on this, you'll probably all Dupaki'd out, but basically it is an incentive paid as a co-payment. So it's a blended payment model. The only payment we receive that is blended, and that is that the practice and the GP both receive a patient. So if your patients are registered, it's $300 to the GP per year or $75 a quarter, and $130 to the practice over for the same amount. So 300 for the GP is the SIP. I didn't mention the 130 because we're talking about SIPs here, but the SIP part of that is 130 to the practice. You have to complete servicing requirements, which I'm sure you're all aware of, and there's some great resources that your PHN has got if you're not. Now, it's 10 past 8, so I can cover off on the chronic disease if you'd like, or would you like to go to questions? Katrina?
Sorry, Wendy, I was just turning off my mute. If there's any questions, please.
Let's do the questions
please,
first.
Yeah, yep. And then
if anyone wants to wait around, we can do that.
Yep, perfect.
Good idea. All right, so Erin, you're going to read me the questions?
Yeah, so if anybody has any questions, feel free to come off mute or pop them in the chat. So far, we've got one from Nicole about the completion of the confirmation of hours. If she has a nurse on annual leave, do you include those hours?
Absolutely.
Yeah, great. I think that's the only one in the chat so far. So does anybody else have any questions?
So either I've covered off really well, or everyone is so gobsmacked that they just can't think of a question. I hope it's the first one.
I think you've covered it really well. It's been very informative.
Thank you. So let's do this then. It's only a 5-minute section. I basically put on, I know that your PHN is offering you future in education around this, so I'll just touch on it really quickly. The chronic disease changes, as we know, were due to come in November last year. There's lots of pushback from the RACGP, and so the government decided to hold off on it, with a planned date being the 1st of July this year. It is still, however, listed subject to legislation, so it's still pending. So there's not a lot of information apart from what was initially released for us. So come the 1st of July, we are going to have, instead of our current GPMP and TCA, which we all know well, we're going to have a new streamlined plan, which will be called the GP Chronic Condition Management Plan. So we're going to have to get some acronyms or some abbreviations for that one, because GPCCMP. Anyway, this will replace the current GPMP and TCA. There will be removal of all the item numbers that we know. So 721, 723, and 732, the actual item numbers are all being removed and replaced with 2 new item numbers. To be eligible for the same incentives that our patients can receive now under the current system, they will only need to have the 1 item number bill. It is the same requirement, so you still need to have a patient whose chronic condition has lasted or will last greater than 6 months. And they must, if they are doing, and there is no requirement though for the 3 providers unless you, so what they've basically done is rolled everything in and made it so much simpler for us. And I'll explain that in a minute. And you still will have the same access to all the allied health services we had previously. They are the new item numbers. So the 965 is our new 721 and 723. And there's a telehealth equivalent, and the 967 is our new 732. What does that mean for us? Basically, it means from the 1st of July, the 965 is the only number you need to bill, whether you are doing a current, what we call management plan, which is just between the doctor and the patient with no one else involved, or if you're also incorporating a multidisciplinary team. Same number, regardless of whether it's just the doctor and the patient, or the doctor, the patient, and a whole team of allied health carers. The removal of the red tape is probably the most significant thing. There's no more requiring collaboration with providers and having to wait to get the facts back before you build the 723, which, if we're honest, I think about 90% of practices don't wait, they just bill it anyway. So they've decided if they're not going to do it, we might as well just stop asking them to do it. So you will not be required to wait for collaboration to justify billing your item number. And there will be a rebalancing of both the 721 or the 965 and the 732 or 967 into equal value. And no, it will not be the current fee. So at the moment, the 721 is $160 and the 732 is around $80. They will not be giving us the 965 and the 967 at 160. If I was a betting person, I would say around 100. I reckon they're going to meet it halfway, maybe 110, reduce one by 50 and put one up by 40. 110 maybe, I don't know, I'm just guessing, so please don't hold me to that. I hope I'm not right, and I hope it's going to be more. And so basically a reduction in the remuneration for our plan, but an increase in the remuneration for our reviews, which is what they're trying to do. They're trying to get us to encourage reviews. How many times do you get a patient who comes in January and wants their care plan and their team care arrangements for their podiatry visits, for their 5 services, they get what they want, and we don't see them until January next year. So in recognition of that, by reducing the remuneration we can charge, the only way we're going to be able to receive similar remuneration is to review those patients every 3 months. So if you do that, if you are a practice that does 721 and 723 every January and does nothing until the next January, you are going to be no worse off. However, if you are a practice like mine who does care plans in whenever they're due and then reviews them every 3 to 6 months, we will be worse off. You no longer require the EPC referral, that piece of paper that never prints properly and you always forget to write the number in, or the doctor forgets to sign it. So they are no longer required. A standard referral will be suitable as long as you list the number of services. Obviously, if you are referring to 3 separate allied health, you need to do 3 referrals. The thing I found interesting here, and I know you're looking at that thinking, why are you saying that? The practice nurses can already do that. The practice nurses can assist the GP in the review of the care plan to bill the 10997, but they cannot help, or they are not able to bill the 10997 if they are preparing a plan. The terminology or the wording now says prepare or review. So I'm hoping that means the 10997 will be available for both preparing and reviewing. So that brings us back to our patient registrations with My Medicare. If your patient is registered with you as a My Medicare patient and belongs to your clinic, your GP is the only one who can provide chronic disease management for that patient. However, if they're not registered, the GP can still do that, but so can anyone else. So they're trying to rule out that opportunistic billing where our patient goes away for a few weeks and has a visit to the doctor for something and comes back with a care plan they didn't even know they had. So that is what they're trying to iron or trying to get rid of. Just a few things to finish up to note. You will need, if your patients have a GP plan in place, they must have it reviewed at least in an 18-month period, or they will no longer be eligible to receive allied health. So it's forcing us to review these. It's the same MBS requirement, so 3 months and 1 day is the minimum, or 12 months between the new plan. Patients who have a 721 and 723 in place now, that should be the 1st of July, I'm so sorry, as of the 1st of July 2024, will be able to continue to claim services under that without having to get a new 965 done in July. As of November 2026, or that should be July 2026, there will be a 2027, your new plan can replace those. And the thing I found most interesting, that come 2026, if your patients do not have a GP CCMP, they will not be able to have a medication review. So that is a restriction. So if they're not being managed under the new plan, then they will not be eligible for a home medication review. So there's a list of resources. They're never ending, but these are ones I found the most valuable. I'm going to stop sharing now because the next slide is purely just questions and see whether anyone has any questions from that. Hope they're all still awake.
I'm sure they are. So there's none in the chat just yet, but if you don't want to come off mute and ask, feel free to put them in.
Yeah, if anyone would like to ask a question now, I'm more than happy to answer if I can. As I did say, I will absolutely provide all the resources I've mentioned through this presentation to your PHN, whom they will distribute to you in a couple of days. But yeah, anyone wants to talk to me?
That's great. Thank you, Wendy. Oh, so I think we might leave it there. It looks like we don't have any more questions, but I'd like to take the time to invite you guys to complete the participant evaluation survey. So Katrina has included that in the chat. And Wendy, yes, you can email questions in the future. You can email them to us and we can even get back to you if we can. And Jenny has said thank you. That was very easy to understand. So thank you again, Wendy. That was really great. And we'll see you guys next time.
Thank you, everyone. Enjoy your night. And big thanks again to Westvic PHN for inviting me. I feel very privileged.
Thanks.
Good night, everyone.
Thanks, everyone.